So the next talk is examination of joint. I don't think you will get a joint examination. For the examination, a long case, usually you won't get. And also, how to approach a case, a clinical examination of hip joint. So, history is very important. So, ask the patient about the pain. Where is the pain? So, usually a patient with hip joint, the pain will be in the anterior, in the groin. He will point it to the groin. So, mostly pain will be in this area. Suppose he is pointing in the lateral side, it is in the mainly related to trochanter. Okay, sometimes in the back, it is likely to be a side joint or something radiating from the lumbar spine. So, characteristic of pain is also very important, whether it is inflammatory, degenerative. So, whether the pain is more at night and early morning pain and stiffness, that is typical of inflammatory arthritis. And night pains also, you should be very careful when the patient complains of night pains. And in children, night cries, that is typical of tuberculosis. So you should go into all aspects of pain. What is the duration, what is the type, what's the radiation of the pain. I have seen patients with having knee pain, the boys complaining of knee pain, but their problem is at the hip. So you should take a thorough history. Then about the swelling. Where is the actually in arthritis, hip arthritis, you won't be able to see swelling because it's a deep seated joint. So look for if there's a swelling, it may be due to another cause like abscess or something else. Then limbing, whether there's limbing, shortening and swelling. These are the typical things you should ask in history. Then you can start with the gait, or the gait you can do at the end of the exam. So actually it is better to do the gait earlier, so you can pick up certain things. So when the patient walks, you can look what is the type, what is he having. So there are different types of gait like endalgic gait, Trendelenburg gait, then limbing due to limb length discrepancy. Then the patient with a stiff joint will have a gait because there won't be much flexion of the hip joint. Then the typical circumduction gait in hemiplegia, and in spastic child you can have a scissoring gait. So there are different types of gait. So by identifying the gait, you can identify most of the problems. So what is an endalgic gait? So endalgic gait, what happens? Patient stands, the stance phase on that affected limb will be short, and the patient will transfer his body weight towards the affected hip just to reduce the momentum. Don't think he will lean to the other side. He will lean to the other side only when the pain is in the knee or ankle. If the pain, it is hip pain, the patient usually lurches to the same side, so that you should know the biomechanics, because the momentum is reduced when you lurch to the same side. And also the stance phase is reduced, and he will take short strides. So this is the typical characteristic of an endalgic gait. So you should look for the stance phase, you should look for the stride, and you should look for the cadence. Okay, and the lurch also. So the lurch is towards the affected side in an endalgic gait. And what about the Trendelenburg gait? Where is the lurch? Is it to the same or opposite side? In a Trendelenburg gait also, the lurch is towards the affected side only. Okay. Only thing between an endalgic gait and a Trendelenburg gait is that the step length, the stance phase is normal in a Trendelenburg gait, and strides are also normal in a Trendelenburg gait. So if the patient is having a bilateral problem, then he will be having a waddling gait. If it is unilateral, the lurch is towards the affected side only. Okay. And what about the limb length discrepancy? Here also the shoulder and the pelvis will be drooping on the affected side only. Okay. So Tunnelenberg test. So what is the Tunnelenberg test? The basic thing. So it could be either due to the problem with the fulcrum. Fulcrum is the hip joint, or it could be a problem of the lever. It can be due to the problem of the fracture neck, or the trochanter, or something, or the head, something like that, the lever problem, or it can be due to the problem of the power generator, that is the gluteus medius. Okay, so what happens in Tunnelenberg gait? What happens when the patient is having problem in the left side? So his gluteus medius is attached to the outer aspect of the ilium, and it is inserted into the, where is it inserted? It is inserted at trochanter, tip of the trochanter. So the insertion is fixed. So when the patient stands, what happens? He actually tries to pull the pelvis on that side down. So this is manifested as an upward rise of the pelvis on the opposite side. Understand? So actually the same side, when you are standing on one limb, what happens? The same side gluteus medius is contracting, and that is pulling the pelvis down. So you are seeing an lifting of the pelvis on the opposite side. Okay. So what happens when the patient is having a problem with the fulcrum, or the patient is having a having a fulcrum on the lever or the muscles? What happens? The pelvis on the opposite side droops, because here your gluteus medius is not acting. So the pelvis on the opposite side droops. Okay. So what happens? The body is shifting toward that side, and the patient will fall down. To prevent that, patient will lurch towards the side of the problem. So this is why the lurch is towards the side of the joint. So how will you test that? How will you test a Tunnelenberg? Usually, what are the prerequisites before testing a Tunnelenberg? There should not be any adductor deformity or abduction deformity. The patient should be able to stand in one limb for at least 30 seconds. Okay. And if there is a limb length discrepancy, you should make some arrangements to correct that, some front blocks. And you should observe the patient. Usually it is said that you should observe the patient from the back. You should look for the gluteal fold or the PSIS. But it is good to look from the front, look for in the anterior superior iliac spine. Okay. Then how much to flex the hip, how much flexion for the hip and how much flexion for the knee. You should not flex the hip more than 30. That is very important. If you are flexing it more than 30, what happens? The iliopsoas will stabilize your pelvis. So pelvis drop will not be appreciated. So always flex the hip up to 30 and knee to 70. That is the amount of flexion that is needed. Then ask the patient to stand. So first explain the patient, ask him to make in the stand on the normal limb, then do it in the abnormal side. Then look for the drop in the pelvis. So that is how you should test the Tunnelenberg test. So if the patient is not able to stand for 30 seconds, you can use assisted Tunnelenberg test. How to do an assisted Tunnelenberg test? You stand in front of the patient, then keep the hand like this and ask him to rest the hand on your hand, then ask him to lift the normal one, then look where there is any force on the hand, then do it in the disease side. Then what happens? In the normal side, he will give more pressure on the normal side. Okay, then he will fall down. So that is then assisted Tunnelenberg test. If the patient is not able to do it stand for 30 seconds. So Tunnelenberg test, you will ask for the exam, how to do it, anything. Then what are the parts in inspection? Never touch a patient without inspecting. So you should go in the usual way, like inspection, palpation, like that. Okay, so you see the patient, feel the patient, move the patient, then measure. That is the usual way you should go. Don't disturb that order. Okay, so you should look for the attitude of the patient, how the limb is kept like that. Then you should inspect the patient from the front, from the side, and from the back. That is very important. So from the front, what all things you should look? you should look about the shoulder, neck, and then you should look the ASIS. You should look the position of the ASIS. So this is the ASIS and here. Okay, so you should look for the position of the ASIS. Then you should look the position what there is some knee flexion, there is some knee flexion, and the foot is plantigrade. So inspection from the front, these are the things you should look. Then from the sides, what are the things you are seeing? So there is lumbar lordosis, and there is flexion of the hip, there is some slight external rotation, and the knee is plantigrade. Okay, so what may be the cause of this lumbar lordosis? There are different causes. Suppose it is an hip flexion deformity. What happens? Why there is lumbar lordosis when there is hip flexion deformity? So when there is a fixed flexion deformity of the hip, what happens? That means you cannot extend your hip. When there is a fixed flexion deformity, you can only flex it further. You cannot extend it further. So you cannot walk like this. So how to walk? To keep it plantigrade, what you should do? Your pelvis should move anteriorly. Understood? Your pelvis should move tilted anteriorly. So when your pelvis is tilting anteriorly, what happens? You will fall down. So to keep your center of gravity back, what you should do? You should move back. That will produce a lordosis. So this is the mechanism by how there is a lordosis in a fixed flexion deformity. Okay. So there is lordosis, there is flexion of the hip. Then you look at the back also. From the back also, look at the position of the shoulder, position of the PSIS, and look for the scoliosis also. Okay, so he is having an adduction deformity. So adduction deformity in a patient, he is having his ASIS is lower down. No. So if the ASIS is lower down, he will be having an abduction deformity. Why? When the ASIS is lower, you are having an abduction deformity. Simple. So suppose you are having an abduction deformity like this. You cannot walk like this. So to bring your foot parallel to the ground, what happens? In an abduction deformity, adduction is not possible. Understood? The opposite movement is not possible in a deformity, which is a fixed deformity. So in an abduction deformity, you cannot adduct. So what happens? You should bring your pelvis down. So when you are bringing your pelvis down in an abduction deformity, what happens? There is an apparent lengthening and your ASIS is down. Okay. So in abduction deformity, you are bringing your pelvis down. So there is an apparent lengthening and ASIS is down. Then what happens? You cannot walk like this. So you should bring your center of gravity towards the side of the side. So what happens? It should be the same side. The scoliosis will be on the same side. Otherwise you will fall. Okay, so the scoliosis will be the same side in an abduction deformity. Abduction. Then palpation. That is, first it is better to mark all this. Mark the ASIS, mark the trochanter, PSIS, all you can mark. How to mark an ASIS? So for marking the ASIS, you should feel for the pubic tubercle, then go along the inguinal ligament. Okay, then the first bony thing you are meeting, that is the ASIS. Then since hip is a deep joint, similar, just like a knee joint, you cannot palpate the joint line. Understood? You cannot palpate the joint line. So how to palpate the joint? You look for the mid-inguinal point. Okay, so mid-inguinal point, where is the mid-inguinal point? Mid-inguinal point is between the symphysis pubis and the ASIS. So between the midway between the symphysis pubis and ASIS, 2 centimeter below and 2 centimeter lateral, you feel that there is a area of the humeral head. So you can feel the joint there, okay, anteriorly in the mid-inguinal point, So it's not the midpoint of the inguinal ligament. So midpoint of the inguinal ligament is different from mid-inguinal point. Midpoint of the inguinal ligament is between the pubic tubercle and ASIS. Okay, so it is the mid-inguinal point. Similarly, posteriorly also from the PSIS to the trochanter, you draw a line, the line between the 2/3 and 1/3. From the medial 2/3 and lateral 1/3, that junction is the joint. Then you palpate in the Scarpa's triangle also. So examiners are very fond of Scarpa's triangle. They will ask the boundaries of Scarpa's triangle. So you should know the boundaries of Scarpa's triangle, contents of Scarpa's triangle. Okay. Then tenderness. This is Morris bitrochanteric test for tenderness. So you should give not just a simple palpation. Simple palpation, there will be pain when there is trochanteric bursitis. But you should give just thrust like this. Bitrochanterally, you give a thrust. Then that will be transmitted toward the joint. Then the patient is having any pain in the hip joint, then will be painful. That is Morris bitrochanteric test. Then another is vascular sign of Narath. That also you palpate the femoral artery pulsation in the mid-inguinal point between just 1 centimeter and lateral to the mid-inguinal point. So usually you are palpating just above the head of the femur. So that will be present. This is positive. You won't be able to palpate when there is destruction of the head or dislocation. Okay, that is the vascular sign of Narath. So these are the palpatory things. Then as I said, there will be deformities. There is the sagittal plane deformity, there is the coronal plane deformity, and axial plane deformities. Axial plane deformities, there is an external rotation and internal rotation deformities. Sagittal plane deformity, what is sagittal plane deformity? You will get a fixed flexion deformity. That is a sagittal plane deformities. So a deformity in a sagittal plane or a coronal plane, that will be, you can mask it. Patient will usually mask that deformity. A flexion deformity, patient will be masking by doing excessive lumbar lordosis. So you are, by doing a Thomas test, you are just unmasking that deformity. Okay, the patient. So how to do a Thomas test also? This will be also, you will get an exam. Definitely they will ask about the Thomas test. Sir, Thomas well-leg flexion test. It is known as well-leg flexion test. Actually, don't make the patient lie down on the floor. Actually, you can lie him on the couch with a firm bed. That is enough. And what you should do, you should squat up to the level of the bed and look from light and look for the lordosis. A light you can see from the other side. That is how you look for the lordosis. Okay, so usually while lying down will be a lordosis because our lumbar spine is having some lordosis. So is it normal to have a lordosis when you are lying down? Any amount of lordosis is pathological. So you won't get lordosis when you are lying down. Okay, only standing only you will get a lordosis. Okay. So it is actually Thomas well-leg flexion test. So how to do this? Actually, you make the patient lie on the floor. Then what to do? You should insinuate your hand. You can insinuate your hand with the palm facing up or palm facing down. Which way you can do? Is it the palm facing up or palm facing down? Some examiners like it with palm facing up, so you do it like that. Some will like with palm facing down. Okay, so both way you can do. If the examiner is saying that it is not, no, it is the palm facing up, it is just like that, Bailey, it is like that, then you say, okay, sir, you can do it like this. Otherwise, you do like this. Both are same, nothing. If it is in the palm, then you can the pulp, you can feel that. It is sensitive. If it is other way also, your knuckle should pass out just beyond that midline. Okay, so that you can have an idea. So you can insinuate your palm both upside or with the palm facing up. So the thing is that always keep that palm there. Don't remove it. I have seen students removing it once they are incinerated. Don't remove it until the exam is over. So you keep your palm there. Then what you should do? You should flex the opposite limb. Okay. So that is also important. Don't be so gentle. You cannot obliterate the lordosis. And don't be so vigorous. You will overdo it. Okay. So just flex the hip. Keep it like that. Look whether the lumbar lordosis is obliterated. Then what you should do? Then you should ask the patient to hold that. Like that you should hold it. Then with the examiner's hand, you should extend the other limb. Then when this lordosis is appearing, that is the period when you should stop. Understood? So don't remove the hand from there. So just give some pressure over the diseased limb. Then when this is trying to obliterate, then that is the angle. Then measure that angle between the coach and the thigh. Keep the goniometer and measure it. Okay. So you can, bilateral also, when there is flexion deformity, you can do this test. You can do this test either by lying down flat or prone. Haley's test is there. Or you can do it in the lying down position also. You can do in bilateral cases. So this is Thomas test. So definitely you will get, someone will ask about this test and do it properly. Then as I said, you will have an coronal plane deformity and that is abduction and adduction, or adduction deformity and abduction deformity. So as I said earlier, usually this patient with having some pathology in the synovitis or something like that, usually will they have an flexion, abduction and external rotation deformity of the hip. That is a usual thing to have. So how to measure it? So I have said that I mentioned the mechanism. So in an abduction deformity, where will be the ASIS? Abduction. Be thorough. In abduction, you cannot adduct. This joint you cannot adduct. So to bring it to the ground, this pelvis should tilt down. Okay. So when this pelvis is tilting down, your limb is going, your body is going like this. So you will fall down. You cannot. This is very energy. You need more energy to walk like this. Okay. So what do? You just bend your spine. So the scoliosis will be to the same side and the ASIS will be lower and there will be an apparent lengthening. Okay. Any doubt? In an adduction deformity, what happens? The ASIS should be high. Okay. And the scoliosis will be in the opposite side and there will be apparent shortening. So how to measure this? There are two methods. One is a Perkins method, another is a Kothari's method. So Kothari was actually a resident of Grants Medical College. He was an anatomy resident, and he described this test. So as a resident, you can also do something like this. Okay. So he published it in the Journal of Surgery, Kothari. So he was a resident. So what is the beauty is that it is actually looking for the geometry. You actually, when the patient is having, you can do it only when the patient is having only the problem on one hip. In bilateral cases, you can't do it. Is it over? 2 minutes. Okay. Sorry. So in bilateral deformity, you cannot do Kothari. So here, what you are in? So in bilateral deformity, you can do, in unilateral bilateral, you can do Perkins method. So in Perkins method, what you should do? You should unmask the deformity. Okay. So what do you mean by unmasking the deformity? You should square the pelvis. By squaring the pelvis, you are keeping both ASIS at the same level. So when there is an abduction deformity, you square the pelvis and keep the ASIS same level, then measure that angle. So that is the angle of the deformity, abduction deformity. Whereas in an Kotaris method, what you are doing, you should not square it. So the limb should be parallel in a Kotaris method. And you draw a line from the center of the umbilicus toward the symphysis pubis. Then you join both ASIS. Then you draw a line from the ASIS to the center. So that is that angle is the angle deformity of the angle deformity angle. Okay, so that is the Kotaris method. So you will be thorough with the Perkins and Kotaris method. I think I'll stop. Okay, then there, how to measure the apparent length? Only this much only, measurements of the apparent length and true length. So apparent length, as I said earlier, apparent length and true length. For doing apparent length, there is no need to square the pelvis. Apparent length you can measure from the xiphisternum and just to xiphisternum to the medial malleolus. So always use some marks to mark that area. Then use a tape and do it. Whereas in true measurement, true length, squaring is very important, and you should keep the other limb also in the deformed position. So that is very important in measuring a true length. So this is how you do for an apparent measurement. So true measurement, so you should keep that, you should square the pelvis, then keep the other limb also in the deformed position, then measure the segments. Okay. Then other method is look for the trochanteric. There is the shortening is supratrochanteric or infratrochanteric. For a supratrochanteric shortening, you draw the Bryan's triangle. Bryan's triangle draw for supratrochanteric shortening. So you mark 3 points, one in the ASIS, one in the tip of the trochanter, and this line between the line drawn perpendicular to the ASIS and this line is the this line you can measure, you can compare it with the opposite side. Okay. So Bryan's triangle you can do it only in unilateral disease. In a bilateral disease, what you should do, you should do the nilatans, you should mark the nilatans line in bilateral disease. So what happens? You should draw a line from the ASIS to the ischial tuberosity and look for the trochanter. Trochanter should be just below, tip of trochanter should be just below this line. So usually you should flex the pelvis, press the hip and knee to 90 degree. That is ideal because then only you can draw a line from the ASIS to the ischial tuberosity. Even if you cannot flex it up to 90 degree, then it is also okay. Why you should do it in flex it 90 degree? Because then it is easy to measure the ASIS to the tip of the ischial tuberosity. Then these are the tests for stability. Before that you should do the measurements. You should look for the ROM, active ROM and passive ROM. Then look for the test for stability. Do an active SLR, that is very important. Telescoping also, you should do how to telescoping. Then this Ortolani Barlow's test. So due to paucity of time, I am not explaining everything. Thank you for the patient hearing.